Invite Dr. Ananda Keshavan, Professor Pediatrics, Government Medical College, Thrissur, and also the scientific convener of this program. Say a few words.
Very good evening, respected branch president Dr. Sindhu, state vice president and senior faculty members Dr. Purushothaman sir and Dr. Sudha madam and state convener Dr. Mohandra sir and all other senior members. So very happy to say that IIP Kozhikode is hosting the second scientific program, because when many medical colleges are not coming forward to present the cases, very happy to see that Galilee is coming for second time. And also, as already mentioned by Prashant, we can see that a lot of opportunity for the young generation. That is the only association in India giving that much of importance for young generation. Case presentation and a paper presentation and also workshop presentation, and we got so many activities for our young generation. I wish the program all the best, and I congratulate Dr. Mohandas and his team for the excellent activities. Thank you. Jai Hind, Jai IIP.
Thank you, Dr. Ananda Keshavan. Now, Dr. Aslam, the zonal coordinator. Aslam. Okay, then I would invite Dr. Shama, who is the mentor for this program, to introduce the case and also to introduce the lead discussant, Dr. Smilu Mohanlal.
Good evening, sir. Very happy to be part of this PG teaching program, especially in front of the teachers who taught me the basics of pediatrics. Today, from Astamins, Calicut, Dr. Shagufa, final year DMB resident, will be presenting a neurology case. I think it will be helpful not only for the PG students, but also for the practicing pediatricians. The lead discussant is Dr. Smilu Mohanlal. Madam is a pediatric neurologist at Astamins, Calicut. And over to Shagufa for case presentation.
Now, over to Dr. Smilu and also Dr. Shagufa.
Dr. Shagufa, you can start with your case now.
Good afternoon, everyone. Ma'am, am I audible?
Yes.
Yes.
Good afternoon, everyone. Today, I'm presenting a case of 2-year-old boy child coming from Vadagara. Informant is mother. History is reliable. Presenting complaints, pain and inability to move bilateral lower limbs for 1 day. History of present illness. Child was apparently normal till afternoon of day of admission. Then he started complaining of pain in both lower limbs. Pain was present diffusely throughout the limbs. However, there was no difficulty in moving limbs. Mother consoled him and child went to sleep. After a few hours, when he woke up, mother noticed that child had difficulty in moving bilateral lower limbs. He was able to sit up from supine position without any difficulty. But when made to stand, child couldn't bear weight on his lower limbs, nor he could wear chappals. Parents noticed that the limbs were loose on dressing him. He could turn from side to side, able to move his hands above shoulder and can drink from a cup. He was able to perceive, touch and hold compress that the mother used to reduce pain. Also noticed reduction in voice volume during this time, according to mother. They consulted nearby hospital and referred to a hospital for further evaluation and management. By the time they reached a hospital, mother noticed that he had difficulty in getting up from supine position also. There is a history of fever, cough and cold 1 week prior to onset of illness. Fever was low grade and cough was dry cough, which lasted for 3 days and subsided with supportive care, according to mother. However, there was no history of deviation of angle of mouth, pooling of secretion, nasal twang of voice, regurgitation of feeds, no history of breathing difficulty, no history of altered sensorium, headache, vomiting or seizures, no history of abnormal sweating, flushing, urinary retention, constipation. No history of drooping of eyelids or fluctuating weakness. No history of trauma for recent IM injection, vaccinations, or fever at the onset of weakness. No history of unknown bite or any drug intake. No history of abnormal pain, rash, discoloration of urine. No history of weight loss, bond pain, or blood transfusion. No history of canned food intake. Course in hospital, on day 2 of admission in the morning, he developed weakness of upper limbs, pooling of secretion, and more reduction in voice volume. Since then, oral feeds were withheld and tube feeding via nose was started according to mother. Over next few hours, mother noticed child also developed breathing difficulty. For that, child was shifted to PICU and mechanically ventilated. Past history, no history of similar episodes of weakness in the past, no history of weight loss or
Dr.
blood transfusions in the past.
Shagufa, can we just summarize the case till now? Then we'll go to the relevant histories accordingly. So with your initial presenting complaints and the history of presenting illness, so what are all the differentials that you thought about and how did you proceed with the case in the due course of time?
So, ma'am, the presenting complaint was pain and inability to move bilateral lower limbs for one day. So at this point of time, I thought of common causes like it can be due to trauma, toxic synovitis, injury that he must have sustained. And then I also thought about bone pains at this point of time. And then it could be due to a neurological cause as well, which has caused pain and inability to move bilateral lower limb, lower motor neuron type of lesion. I also thought of stroke at this point of time because of the inability to move, but because of the bilateral presentation and the pain, which was against that point. And then in the due course of presenting illness, it was found that the child developed bilateral, symmetric, ascending, progressive kind of weakness, which also in the due course of time involved bulbar and respiratory paralysis as well. So this possibly could be a case of acute flaccid paralysis with the lower motor neuron, probably lower motor neuron kind of weakness at this point of time.
Okay, what are the points that are against an upper motor neuron type of involvement over here?
There is no history suggestive of altered sensorium, vomiting or seizures involving cortical showing cortical involvement, and also it is a bilateral symmetric kind of weakness, and also sensory involvement is there, that is pain, which is unlikely to be caused by a upper motor neuron type of lesion.
So from the history wise, you have localized the system to be a CNS involvement rather than a musculoskeletal involvement. So the points that made you think not about the musculoskeletal involvement was the progression type of the weakness that the child was having. Though the pain that was the initial symptom, the pain and the weakness can be the commonest cause that we were seeing in our OPDs till now was the myositis, because that's how the child usually presents with viral myositis, where they present with pain and also with the weakness of the lower limbs. But here the unusual part was it was progressive. It was also having some involvement of the voice and very rapidly progressive condition. So that is one thing that made you think more of the CNS involvement and rather than the musculoskeletal other part of involvement as such. Then the other component in your history was we know that it is not a upper motor neuron, mainly because of there is no encephalopathy, no seizures, no altered sensorium as such, because the child was crying throughout and a low quality of voice was being observed over here. Okay, so what made you think of more of why lower motor neuron? How do we say that the lower motor neuron type of involvement? Why peripheral nerves alone? Why not neuromuscular junction, and why not a nerve per se or a muscle per se?
Ma'am, if it is a muscle involvement, it is unlikely that it is like rapidly progressive and ascending.
Okay.
And if it's a muscle involvement, if it's a viral myositis, there can be a history of recent fever at the onset of weakness. And it is unlikely to involve bulbar and respiratory cause if it is peripheral muscle involvement, lower motor neuron muscle involvement.
Okay. So basically, you're telling something on the peripheral nervous system involvement rather than the lower motor neuron. So it's a peripheral nervous system, one by one point, you're being ruled out with your history. So if it was a neuromuscular junction, we would have got a ptosis and
Fluctuating
the
weakness.
fluctuating weakness would have been there. And it's not that rapidly progressive like this. There will be some evidence of ptosis prior to this. Okay. Go ahead.
Antenatal history. His second born of non-consanguineous marriage, regular antenatal checkups done, no history of GDM, PH, hypothyroidism or urinary tract infection. Antenatal scans were normal. Natal and postnatal history, term baby born to LSCS, birth weight of 2.3 kg, cried soon at birth.
IAP. మా ఫ్రెండ్ కి త్రిశూర్ లో పడింది మేడం. ఐఏపి కేరళ వాళ్ళది కోలికోడ్ అని మెడికల్ కాలేజ్ వాళ్ళది వస్తూ ఉంటది మేడం. హిస్టరీ కేస్ ప్రెజెంటేషన్స్ ఇట్లా బేబీ పోస్ట్ నేటల్ హిస్టరీ అడుగుతారు మేడం. ఎట్లుంది అనేది, ఎట్లా క్రైడ్ ఇమిడియట్లీ బర్త్ లేదా, వెయిట్ ఎంత, డెలివరీ ఎక్కడ, ప్లేస్ ఎక్కడ అని, తర్వాత మెటర్నల్ కాంప్లికేటింగ్ ప్రెగ్నెన్సీ ఏమన్నా ఉందా అని నేటల్ హిస్టరీ కూడా తీసుకుంటాం కదా మేము.
కంటిన్యూ మ్యామ్.
అదే చేస్తా ఉంది.
Can everybody please mute your audio if it is okay? Please, a kind request to mute your audio. Yeah, thank you. Yes, Dr. Shagufa, I can continue.
Right, soon at birth. There's a history of NICU admission for 10 days for sepsis, discharged on day of life 50. Development history, child have attained all the developmental milestones appropriate for age. Now at 2 years of age, gross motor, child walks up and down stairs 2 feet per step. Fine motor, can draw vertical and circular strokes. Social and adaptive, now child asks for food, drink, toilet and knows his full name. Language, now the child can speak 2 to 3 word sentences, ask questions and knows full name. Hearing and vision appears normal according to mother. Dietetic history, exclusively breastfed till 6 months. Complementary feeding started at 7 months with ragi and banana powder. Now sharing family food diet, getting a calorie of 870 kilocalorie per day with a requirement of 1060 kilocalorie with a deficit of 190 kilocalorie and getting a protein of 17 gram, which is adequate. Immunization history, fully immunized according to National Immunization Schedule. BCGs are present. Last vaccine was taken at 1.5 years of age. That is 6 months back. No adverse events following immunization. No additional vaccines were taken. Family history, first born of non-consanguineous marriage. No history of similar illness in the family or neighborhood. Socioeconomic history, father working abroad in a hotel, mother is a housewife, 4 members, belongs to upper middle class according to modified Kuppuswamy scheme. Summary at the end of history, it's a 2-year-old child, first born of non-consanguineous marriage, developmentally normal, history of lower respiratory tract infection 1 week prior to onset of illness, presented with pain in lower limbs followed by acute onset of bilaterally symmetrical ascending weakness involving all 4 limbs, progressive with history suggestive of bulbar involvement and respiratory paralysis.
Dr. Sharma, do you want to ask any questions at this point of time?
If there is any past history of similar illness, what will you consider? What are the possibilities if there is any recurrent symptoms?
If it has a past history, you can all consider periodic paralysis, hypokalemia, periodic paralysis, and very rarely a few percent of GBS can also relapse. So I will consider that too.
Okay. If there is any family history, any consideration, any other DD will you consider?
There is also entity familial hypokalemia, periodic paralysis, so that can be considered.
Okay.
Okay, so here at the end of the summary, what we have to do is once with the history itself, we have localized it. It is the peripheral nervous system that has got involved. And in the peripheral system, we have various axes. So whether it is the brainstem or the spinal cord or the anterior horn cell or the radical, the nerve, the neuromuscular junction or the muscle. So it is these are the different axes of the peripheral nervous system. So where exactly do you think that you're localizing at the end of your clinical summary?
Ma'am, anterior horn cell, it is unlikely because it's a symmetrical weakness.
Shall we go from the beginning, like from the brainstem? So why do you think the brainstem is not the primary area of involvement over here?
Ma'am, in case of brainstem, as said, there is no encephalitis kind of a feature here, first of all. And then it is a distal to proximal kind of progression.
Okay, so the main thing is if it is a brainstem involvement, you will get an altered sensorium because all your the ascending reticular nervous system and the ascending reticular and everything, descending reticular, so they control your awake and the sleep cycles and everything. So if that is going to get affected, then the child is going to present with altered sensorium, which is not the case over here. So the brainstem is being ruled out, and it is not the early cranial nerve involvement that we are seeing over here. So those things will make you rule out the brainstem involvement to begin with. Coming to the spinal cord, why is it not a spinal cord infarction or a spinal cord compression? So why are or a transverse myelitis? So what are the points that makes you tell that it is not the spinal cord involvement at this point of time?
From history, madam, there is no fever at the onset of illness, and
Okay.
there is no sensory level or that could be found out from the history, and no bladder involvement also. But this age, it's difficult, but still there is no early bowel and bladder involvement.
And usually what you get is an early bladder involvement with transverse myelitis. So the early bladder involvement is not there in this particular case because there was no urinary retention as of now in the history so far. So that made you to consider less of a transverse myelitis or any other cord per se involvement. And if there was a compression, we would have got a severe pain at that particular site, which is also not there. And there is no history of contact with tuberculosis or no history suggestive of tuberculosis at this point of time, which is one of the very common cause of compression type of a myelopathy that the child can have. So then next, coming to the anterior horn cell. So what are the points against anterior horn cell at this point of time?
Anterior horn cell involvement, ma'am, if it's poliomyelitis, there'll be definitely a history of fever at the onset of paralysis, and it could be mostly of a patchy, asymmetrical kind of involvement rather than a symmetrical, symmetrical involvement.
Right.
And
Okay.
sensory
So
involvement also, pain is also there.
yeah, pain is something not very commonly that is seen, though poliomyelitis children also used to have pain, but the pain is not a usual presentation with the anterior horn cell type of involvement, and the weakness will usually be patchy. That is one thing that goes against the anterior horn cell involvement. Then coming to the radicals, why do you think the radicals are the involvement at this point of time?
Radicular involvement, ma'am, initially it started with pain in the lower limb, and then it has progressed, and the progression is like bilaterally symmetrical ascending kind of weakness, and also there is mild sensory symptoms, and also bulbar involvement, and eventually respiratory failure, and no bladder bowel involvement as such, but transient bladder involvement can occur as well. But I think we can localize it to nerve radical.
So the pain is the most important point that makes us think about the radical involvement as such. So though we say that GBS, the one which that's the commonest cause that affects the radicals, are the presence with asymmetric paralysis. We do see GBS which are asymmetric in clinical practice. Then coming down, why is it not a nerve involvement or a muscle or a neuromuscular junction? You can group all these things together.
Ma'am, similarly, if it's not a neuromuscular junction because there is no ptosis and there is no fluctuating weakness.
Fatigability rather.
Fatigability, it's not there. So it's unlikely to be a neuromuscular junction involvement. And muscle also, muscle involvement is unlikely to produce such rapidly progressive ascending kind of weakness with bulbar and respiratory paralysis. And here both distal and proximal muscles are equally in.
What are the causes of that muscle? If it is a muscle involvement, what are the causes that you should be thinking about at this point of time?
Muscle involvement, most common is electrolyte disturbances, hypokalemic periodic paralysis, or we can consider viral myositis, polymyositis.
Okay. Yeah. Okay. And why not a snake bite? That also we see commonly with presents like this. Why not a snake bite?
Snake bite, ma'am, it's usually affect the neuromuscular junction and we get a ptosis initially if it's a
If it's
snake.
a neurotoxic snake bite, and you get a ptosis, ophthalmoplegia, and more of a descending and early respiratory type of involvement will be there. Okay. Yeah. Go ahead.
General examination on day 2 of admission. It was done day 2 of admission before respiratory paralysis happened. Child was alert, no pallor, icterus, cyanosis, lymphadenopathy, edema, no facial dysmorphism or neurocutaneous markers. Vitals, pulse rate of 92 per minute. It was in regular rhythm, normal volume and character, no radiofemoral delay. Respiratory rate 24 per minute, abdominothoracic, no paradoxical breathing at the time of examination. Blood pressure 90 over 60 millimeters of mercury, right upper limb in supine position, capillary filling time of less than 2 seconds, and temperature was 98 Fahrenheit. Examination.
Can please everybody mute the.
Please mute.
Yeah, please mute, please. Thank you. Yeah,
Head
go
to foot
ahead.
examination. Head appears normal in size and shape. No facial dysmorphism. Eyes normal. Throat and tonsils normal. No bite marks, rashes or hyperpigmentation. Abdomen and external genitalia normal. Anthropometry. Weight of 13 kg. According to WHO charts, it lies between 0 and +2 Z-score, which is normal for age. Height 86 centimeter between 0 and +2 Z-score, which is normal. Head circumference 48 centimeter between 0 and +1, which is normal. And mid upper arm circumference is 15 centimeters, normal for age. Coming to nervous system examination, higher mental function. He was alert, slightly irritable, but interacting well with mother. Speech comprehension was normal, but reduced volume of speech and had a nasal twang of voice. Cranial nerve examination. First cranial nerve not tested. Optic nerve. Gross vision appears normal, color vision normal, and fundus examination was normal on both sides. Third, fourth, and sixth cranial nerve. Extraocular movements full in all directions bilaterally. There was no ptosis. Pupils were equal and reactive to light. And fifth cranial nerve, there was no deviation of jaw. Sensation over face appeared normal. Jaw jerk was not tested. Facial nerve examination, bilateral forehead wrinkle was present bilaterally. He was able to close both his eyes tightly. There was no deviation of angle of mouth. Eighth cranial nerve, hearing appeared normal. Ninth and 10th cranial nerve, there was a nasal twang of voice, reduction in voice volume, uvula central, gag reflex was absent. 11th cranial nerve, able to turn head sideways, able to shrug shoulders bilaterally. 12th cranial nerve, no tongue fasciculation were noted. Now, motor system examination, bulk was comparable on both sides. There was no wasting or atrophy. Tone, inspection. Child was lying on the bed with hands by the side, extended at elbow with palms facing up, both lower limbs abducted at hip, extended at knee, and the lateral aspect of feet touching the couch. Palpation, flabby to touch. Passive movements showed hypotonia bilaterally in both upper limb and lower limb. There was also truncal hypotonia. Power, shoulder, adduction, abduction, flexion, extension, 3/5 bilaterally. Elbow flexion extension 3/5 bilaterally. Wrist flexion extension, supination, pronation. Flexion extension was only, he was cooperative. That was 3/5. Hip flexion extension, adduction, abduction, 1/5 bilaterally. Knee flexion extension, 1/5 bilaterally. Angle, dorsiflexion, plantar flexion, 1/5 bilateral. Superficial reflexes, corneal reflex not done, conjunctival reflex was present bilaterally, abdominal reflex was present, and plantar was flexor bilaterally. Deep tendon reflexes, biceps, triceps, supinator, ankle, knee and ankle jerk were absent bilaterally. Sensory system were able to test for light, touch, and pain. which was normal, right and left. Vibration, joint position sense, tactile localization, 2-point discrimination, stereognosis were not tested. No abnormal movements. Autonomic system, there was no flushing, tachycardia, or excessive sweating. No meningeal signs were able to elicit. Spine, no tenderness or no mass palpable. Cerebellum, there was no cerebellar signs, no nystagmus. Other signs could not be elicited. Other systemic examination, respiratory system, normal vesicular breath sounds heard bilaterally. There was no paradoxical breathing, no added sounds. Gastrointestinal tract examination, oral cavity was normal, per abdomen soft, no hepatosplenomegaly, no palpable bladder, bowel sounds heard normally. Cardiovascular system examination, apex beat felt at the fifth left intercostal space in the mid-clavicular line. First and second heart sound were heard, no murmurs. So summary, a 2-year-old child, first born of non-consanguineous marriage, developmentally normal, with history of a lower respiratory tract infection 1 week prior to onset of illness, presented with pain followed by acute onset bilaterally symmetrical ascending paralysis involving all 4 limbs, both proximal and distal muscle involvement, which was progressive with bulbar and eventually respiratory failure. On examination, he was a conscious child, flaccid quadriplegia, absent deep tendon reflexes with bulbar palsy, no sensory level. So it's a case of acute flaccid paralysis, lower motor neuron type of weakness, localization to nerve radical, and etiology, it's most probably Guillain-Barré syndrome.
Okay, can I just interrupt over here? Okay, I have a couple of questions. So here, can you tell me the root values of all these reflexes like biceps, triceps, supinator, knee and ankle jerk? This is for the PGs to know the root values. That's very important to know that.
Biceps, ma'am, C5 to C5, C6. Triceps, C7, C8, C7, C8. Supinator also C5, C6. Knee jerk, L2, L3, L5. Angle
L2, L3, L2, L3, L3 and
angle jerk, L5, L5, S1.
Okay, okay. So we need to know, and here you had mentioned about the upper limb power was 3/5 and the lower limb group of muscles, the power was 1/5. So when the upper limb power is also 1/5, for example, the shoulder flexion, extension, abduction, everything is 1/5. So what should be your worry at this point of time? Suppose you are a pediatrician working in a peripheral hospital and a child has presented with a weakness like this. So when do you know that this child would need immediate referral to a center which requires ventilation? So what are your points that you need to monitor at this point of time? Suppose if the upper limb power is 1/5, so in what would be your worry at this point of time?
That is, child is going for an impending respiratory failure. If the shoulder movements are also affected. So deltoid involvement is a red flag sign to know that the child is probably will go to respiratory paralysis and needs mechanical ventilation.
So child may have a diaphragmatic paralysis also, which can set in at any point of time. So the child would need an immediate ventilation at this point of time. So that is the reason why you should be wary about these signs. Okay, can we, so basically your examination was nothing but you're just confirming your findings that were all been elicited in your history. So in the history itself, you localized it to the peripheral nervous system involvement, in which your neuraxis that you were suspecting was the radicals, and all your other findings were in corroboration with the clinical findings were in corroboration to say that the radicals have got involved, and the likely etiology that you're considering is GBS over here, right?
Yes.
Okay. Suppose if your patient had presented with ptosis and ophthalmoplegia with similar setting of weakness. So is it GBS or is it neuromuscular junction?
Ma'am, Miller-Fisher variant of GBS can present with ophthalmoplegia.
Yeah, so Miller-Fisher variant of GBS can present with ophthalmoplegia, so that we should be aware about it, because we do get confused at that point of time, because in the initial stages they need not have areflexia. Though we say that the Miller-Fisher can present with ophthalmoplegia, ptosis and areflexia need not be there in the initial point of time. So that also we should be careful about it, because we have seen such clinical scenarios and instances. Okay. Dr. Sharma, do you want to contribute here?
Okay, if such a child with progressive weakness is admitted in your ward, what all will you?
Dr. Sharma?
Hello, am I audible?
Yeah, you're audible now. We
Am I
are
audible, ma'am?
not.
Okay, okay.
Yeah, you're audible, but in between we are breaking. You're okay. Dr. Shagufa, you continue. Dr. Sharma can ask in between. Yeah.
So coming to the investigations, we can do a basic blood count and serum electrolytes to rule out any electrolyte abnormality. As we have already discussed, potassium, calcium, magnesium, phosphate can be looked for, and serum CPK also. Then according to AFP surveillance tool, samples has to be sent. We can do a CSF study, MRI spine, and most importantly, nerve conduction study as well, to confirm our diagnosis of Guillain-Barré syndrome.
Okay. What is the first investigation that you would do over here? Like, definitely you're going to do bloods and electrolytes and all, because you're not yet with the clinical history or thinking it suggestive of GBS. But what is the most important investigation that's done in the early week of illness? So basically the child has presented you right now where just one day has been the onset of weakness, and it is a clinical diagnosis you are thinking of GBS, but what is the first investigation that is required, and what is the abnormality that you see in the first investigation?
Ma'am, I will do a nerve conduction study first compared to the CSF study and MRI spine, because in the
Right.
first week of illness, it is likely to be positive than the other two investigation.
Okay.
It will help us to rule out whether it is a demyelinating form of GBS or an axonal form of GBS in nerve conduction study. And if it is a demyelinating form, we'll get prolonged latencies, reduced conduction velocities, conduction blocks, and temporal dispersion. And if it's an axonal form, there will not be any signs of demyelination, but the compound muscle action potential amplitude will be less in case of axonal forms.
Okay, so here the point that I wanted to add was the first and foremost feature. So usually GBS is a clinical diagnosis. That is the first thing. Rest all the investigations are just corroborating to your clinical picture. So here the first investigation is nerve conduction that you already said, but to get a clear-cut picture of prolonged latencies, conduction velocities, it usually takes into second and third week. Only 50% of the cases will have this prolonged latencies and conduction velocities by second week, and 85% of them can have these abnormalities by third week into the illness. The first and foremost feature that you would see in nerve conduction study is the absent F and the H reflexes. So what are these F and H reflexes? This is nothing but they indicate that the proximal component of the nerve is getting involved. That is nothing but the radicals are getting involved. So that is what will be seen as the initial site. So many times you will get normal conduction velocities and everything. Because this child was rapidly progressive, we could get some abnormalities in the NCS, but not the same in all the time. Okay, so and what is the second investigation that you would do if the nerve conduction study the first week you have done, and second week the child is behaving in a slightly atypical way? So what is the next investigation that you would go in the line of treatment?
Towards the second week, we can do a CSF study, ma'am. We can get the albuminocytological dissociation, where the protein will be more than 40 and the pleocytosis will be less than 10 cells. So that
Okay.
is quite diagnostic of GBS.
Okay. So when I said that the GBS is always a clinical, most of the time a clinical diagnosis, do you know about any criteria by which you can call, with the help of which helps you to conclude that it can be a case of GBS?
Ma'am, modified Asbury's criteria for GBS, where
What are the components of modified Asbury's criteria?
the required criteria is progressive weakness of more than or equal to 2 limbs, and there'll be areflexia, and the total disease nadir will be less than 4 weeks with the exclusion of other causes. And the supportive criteria would be progressive ascending bilateral weakness and mild sensory involvement, respiratory and muscle involvement, no fever at the onset of weakness, and CSF study showing albuminocytological dissociation.
Right. It's CSF is supportive criteria rather. Okay. Can you show me the values of nerve conduction study if you have got it? Because there is a question regarding
whether and that was not able to.
Okay, right. So here it was mentioned that the motor nerve studies, both motor and ulnar nerves, CMAPs are inelicitable. Both common peroneal nerve CMAPs have prolonged latencies, decreased amplitudes, and reduced conduction velocities. So basically, with the help of the values, you can come to a conclusion whether it is an axonal type or a demyelinating type. So for a demyelinating type, you need a prolonged latencies, like what you had already mentioned, prolonged latencies, decreased conduction velocities, and also a temporal dispersion or a conduction block will be seen to call it as a demyelination. To call it as an axonal variant, your CMAPs will be reduced. That is more when compared to the latency getting prolonged. So that's how we call it, whether it is axonal or whether it is demyelinating type. So this child had both motor and sensory, right? Motor and sensory. So what is the most common type of GBS that we come across? Most of us.
Acute inflammatory demyelinating polyneuropathy, polyradicular neuropathy, and also acute motor axonal neuropathy and acute motor and sensory axonal neuropathy. And in the Indian population, axonal types are more common.
Demyelinating is more common. Demyelinating is more common. Okay, because and which one is a better prognosis? Is it the demyelinating one which is better prognosis, or the Aman and the Amsan variants which are of better prognosis?
Demyelinating has a good prognosis, ma'am, than axonal.
Than axonal variant, right? So you can go ahead. Any more slides that you want us to show?
No, ma'am.
Okay. Dr. Sharma, do you have any further questions?
Okay, ma'am. Dr. Shagufa, if a child with this acute ascending type of paralysis is admitted in ward, what all things will you monitor on a day-to-day basis?
I would like to monitor, first of all, the respiratory rate, whether there is a tachypnea or hypoventilation, that diaphragmatic paralysis. As already discussed, I look for the shoulder abduction. And I look for the swallowing dysfunction, pooling of secretions, if there is any weak cough, and then reduction in voice volume, nasal regurgitation also. And I'll also look for the any autonomic symptoms like tachycardia, postural hypotension, and also daily monitoring of the muscle power.
Okay, suppose this was a 10-year-old child, what other tests can be done to assess respiratory, to assess if the child is going for a respiratory failure?
We can also look for the single breath count.
Okay.
If it's an older, if it was an older child, we can also look for the single breath count.
Breath count and spirometry also.
Spirometry.
How do you perform a single breath count?
We'll ask the child to, after a normal or deep inspiration, we'll tell the child to count as much as possible. And 25 to 30 is normal. And when it goes below 10 to 15, we should be alarmed of the respiratory paralysis.
Okay. So how do you treat this child? how do you treat the child? Treatment aspect. This child has come to you, the child has worsened, the child has gone into ventilator in 24 hours of time. So how are you going to treat this child?
Treatment, ma'am, general supportive care is very important in the management of GBS. We'll start with, we can give a pain control, and then if respiratory paralysis is there, ventilation aspect should be checked for. And since there is a bulbar palsy, nutritionist support should be given. Deep vein thrombosis, prophylaxis and physiotherapy also should be added in the general management. And in the treatment per se, we can give immunotherapy in the form of IVIG, 400 mg per kg per day for 5 days. And plasma pheresis and plasma exchange are also the other options.
Okay. Suppose this child presented to you on day 25 of illness and was not this bad. Like the child was having a gait abnormality. The gait abnormality persisted around the same time and it has not progressed further. But it is still, the child is still having some weakness in his lower limbs. The power is like 4/5. So will you treat or will you not treat this child?
Ma'am, IVIG and all are unlikely to be effective after 2 weeks of onset of paralysis. So at that point of time, if it is not that severe, we can wait and watch.
So more than it being not effective, it is like the natural course of GBS itself is that the progression will happen in the first 4 weeks. So already the child is remaining stable, has not progressed till day 25, 26, 27, 28. The child is doing almost the same. So we know that the GBS, even if we don't provide a treatment and if the child is having a subtle weakness, will automatically is going to recover. So only when the child is having a progressive weakness leading to all these complications, that is the time we need to actually start providing treatment for these children. Otherwise, a supportive measure will help in that condition also. So what is a pain relief that you would give if the child is having this radicular pain?
Ma'am, we can give gabapentin, that kind of drugs for the pain control if there is intractable pain.
Gabapentin or pregabalin?
Pregabalin.
Pregabalin. Okay. So if it was a transverse myelitis, how would you go about? Suppose the child had a definite sensory level and the child had a bladder involvement. So what would be the first investigation at that point of time? So here it was a clear-cut GBS. We went directly with the nerve conduction. We proved all these features and we went ahead with giving IVIG. And the child is doing okay so far, fine. So if it was a transverse myelitis where the sensory level is very clear, so what would be the first line of investigation at that point of time?
MRI spine, ma'am?
Yeah, MRI spine with contrast, without contrast, how would you go about?
MRI
With contrast.
spine with contrast will show enhancement of the segments involved.
Yeah, segments of the cord. So what is the common antibodies which are associated with transverse myelitis? Any antibody that you are aware of that can cause transverse myelitis?
Neuromyelitis.
NMO, and more common than NMO is?
MOG.
MOG. So it's not NMDA, it is the NMO and the MOG which are related, and in children we see a lot of MOG when compared to NMO cases. And your management would be?
Steroids, methylprednisolone.
How much mg per kg?
Pulse dose 30 mg per kg.
Yes, 30 mg per kg of steroids over 5 days you would consider to give it if it is a MOG related, and MOG has to be tested, NMO has to be tested in such cases. Okay, so Dr. Sharma, do you want to ask any more questions here?
Along with immunotherapy, what all supportive treatment should be given in a case of GBS? Supportive treatment is very important along with immunotherapy. What are those?
Supportive care in the form of pain management and then nutritional management. They might have bulbar palsy, so NG tube feeding nutritional aspect has to be looked for, and supportive respiratory. If it is a respiratory diaphragmatic paralysis, ventilation, respiratory support should be provided, and also skin care, and if because of immobilization, chances of DVT is also high. So DVT prophylaxis and physiotherapy, including chest physiotherapy, should be started. And
Okay, there is also a risk for gastric paralysis, so constipation must be quickly addressed. Then pressure sores.
okay.
Okay, so one aspect that we did not cover is what are the etiological agents for GBS, the vaccine associated and the organisms associated. And a few words on acute flaccid paralysis surveillance and reporting, which all of us should be aware about at this time.
Ma'am, the etiological agents, most common Campylobacter jejuni. It can precede a gastrointestinal infection caused by Campylobacter jejuni, and also Helicobacter pylori can also cause. And respiratory agents like Mycoplasma pneumoniae, EBV are also known to cause GBS, and also CMV, HIV, and all. And when related to vaccination, influenza vaccines, then rabies vaccine, then influenza, rabies, JE vaccine, that can also cause GBS.
Okay, and what is AFP reporting? What is AFP surveillance? Just a brief lines on that aspect, because we need to report to AFP surveillance need to be done for these patients.
Ma'am, AFP, according to the AFP surveillance, AFP is defined as any onset of weakness or floppiness of any part of the body in children less than 15 years or in any age where polio is suspected. And so we should report every case of AFP every case of AFP to the duty MO, and also we have to continue the surveillance of polio by sending 2 stool samples within the first 14 days of onset of weakness, 24 to 48 hours apart, which should be of adult thumb size 8 to 10 grams, which is collected with 24 to 48 hours apart, and should be sent in a reverse cold chain to a WHO accredited laboratory, where it would be evaluated to know if it is a wild strain or not. Any case of AFP, even if it's a GBS, we are quite sure should be reported.
Do you know any disability criteria for monitoring these children?
In GBS, we can look for Hughes disability criteria. Where zero is normal, 1 is mild symptoms, 2 is you can walk more 10 meter with support, we can without support, and 3 is you can walk, he cannot walk 10 meter, and then 4 is where he has this respiratory needed mechanical ventilation, and 5 is he's dead.
Right. So it is 0, 1, 2, 3, 4, 5. So that are the 6 gradings of the Hughes criteria, which modified Hughes disability criteria that has been used for monitoring these children. Okay. So first, the overall summary is that when we have a child in front of us, need not be like when the initial presentation is pain and weakness of the lower limbs, we not only should we consider the the peripheral nervous system as an initial thing, but we should also go for other differentials like myositis, sickle cell crisis. Other things, other system should also come in our mind and need not get system oriented over there. By the end of your history, we should be very clear about the neuraxis. That is, where have we localized, whether it is central nervous system or a peripheral nervous system, and break the peripheral nervous system into brainstem, spinal cord, anterior horn cell, radical, nerve, neuromuscular junction, and the muscle. So that is how we get. So one question that has come was, do we have any clinical clue whether it is axonal or demyelinating? Yes, there is a clinical clue. Any rapidly progressing ones with a respiratory muscle involvement is likely to be axonal variant, which is more severe. So the demyelinating ones usually are not that severe when compared to the axonal ones. So usually the axonal ones we get where the child goes to school in the morning, by next day morning the child is in ventilator. So that is how we differentiate between the axonal and the demyelinating with seeing the child per se. And next dilemma occurs on the treatment aspect, because if you are having a child where in front of you, whether the parents are ready to do anything to save the child, as a doctor you're ready to do anything to save the child, and you want to know whether you want to give plasmapheresis versus IVIG. So here the dilemma always occurs as to what to be given first. So it all depends on the availability of the resources and the setting what we are working, because there are many clinical case reports, studies which say that one is superior over the other, the combination is better over the other and everything. So if you have a child of around 60 kg and you know that the IVIG requirement would be more than 100 gram, and you're working in a private setup where it is going to be extraordinarily expensive for this child, and we do not know whether the only IVIG is going to work because it could be an AMSAN variant in front of you. So in such conditions, as a institutional base, we always prefer to give plasmapheresis first, see how the child is improving. If the child is not improving, then go for IVIG later on, later period of time. But if you're having both the resources, then you can definitely try IVIG first and then after go, because that is a standard, the line of treatment IVIG. And then later on, if the child is not improving even after 4 weeks, then you can consider plasmapheresis at that point of time. So that is thing. And whenever the child, we have got mask many times, because a child presenting with ptosis, ophthalmoplegia, and the reflexes are still present, many a time we have considered the child to be myasthenia. And sometimes what happens is, because these children will have a neuropathy feature, like definitely the conduction velocities are low. When the conduction velocities are low, when you try to do a repetitive nerve stimulation test, even that can actually falsely be interpreted as positive also. So always be careful with the Miller-Fisher variant of GBS and this myasthenia coming at the same time, because sometimes the parents will say that where his eyes have been like that photic. So we do get confused at that point of time. So these are a little bit of experiences and takeaway points from my side. Any questions to Dr. Shagufa or to me or to Dr. Sharma? I think we have managed. What somebody asked about CBD. Can somebody tell me, Dr. Indu, what was the CBD? I did not get it. If you can be clear. Dr. Indu, are you there? Continuous bladder drainage. So yeah, so continuous bladder drainage only in the acute situations we do provide, because otherwise what happens is, if the child is not having a bladder involvement per se, and the child is on ventilator, only when the child is on ventilator per se, we use a catheter. So otherwise we wait with the diaper change and everything, if the child is not having a bladder retention. If the child is having a retention, then we need to do a continuous bladder drainage. Dr. Shagufa, can you answer that question? Is autonomic dysfunction very common in GBS?
Yes, ma'am. We have seen cases with GBS having autonomic dysfunction of cardiac disturbances and also hypotension.
Hypertension also.
At presentation also.
Yeah, how much percentage can you be sure about it? Any idea?
That I don't know.
We'll get back to you. Even I'm not good at percentages. Okay. Anything else? Mohandas sir, Sindhu ma'am, are you there, ma'am?
Purushothaman sir, എന്തെങ്കിലും comment ഉണ്ടോ?
There is a question in the chat box. Can you say about your experience with the plasmapheresis?
experience with plasmapheresis. Okay, so here, like I said already, we have this protocol where a child is beyond 30 kgs, because here the main problem that we face is the affordability issues. So we go for plasmapheresis first, and we can say that the AMSAN variants have done pretty well with plasmapheresis, because without that, if the recovery period has been like 4 weeks, with plasmapheresis, we have seen a recovery period like in 2 to 3 weeks duration, and we have been able to wean them off the ventilator. This particular child, though the child had an AMSAN variant, underwent both plasmapheresis and IVIG, and the child is doing pretty well. We thought the child will go for tracheostomy because of the rapidity of involvement, but the child came out pretty well without a need for tracheostomy. The lower limb power has improved. The upper limb also, the power has come up to 3/5.
Okay, thank you.
So will there be recurrence of symptoms with similar triggers in future? Yes, there can be a chance of recurrence. As I think it is around 5% that can recur. I'm not very sure about it. But sometimes what happens is the proximal muscle weakness of the lower limb can remain for a quite longer period of time. So they can remain like 6 to 7 months period of time. And suddenly, if you have not seen the child anywhere in between, and at 7th month, they'll bring you the child and they will tell you that the child is having weakness, then you get confused whether it is a new onset weakness or it was a persisting weakness. So these children need to be followed up, like after discharge also every monthly they need to be followed up, so you know what their muscle charting has been. That's why I asked about this Hughes disability scoring, and also that whenever somebody sees and notes it down very clearly, it becomes easy for us to monitor these children over a period of 1 to 2 years of time. CPK is a very non-specific investigation, because a CPK may not be elevated, though we see some percentage children with CPK elevation as such, but it's a very non-specific one. A CPK monitoring may not help in this case of GBS. CPK will be helpful for viral myositis.
Sagofa, will you switch off that screen sharing? Sagofa, will you
Yes.
off that screen sharing? Stop that screen sharing.
Okay.
Okay, a few comments. Well discussed case of both. All three of you.
Thank you, sir.
Then a few comments from the pediatrician side. In the initial history elaboration, always the purpose of the history. There are two purposes of the history, Sagopa.
Yes, sir.
One is the anatomical localization, where exactly in the neuroaxis. It may be in one side, more than one side in this case, in the lower part, and there is a scattered area in the swallowing part. So there can be more than one side. So history points to delineate the anatomical localization. The second part and the severity of that neurological aspect. And the second aspect of the history is the clues for the pathological basis. And after that, the past history and everything again is helpful for these 2 points, especially for the pathological basis. And few of the past history out of this recurrent episodes are again helpful for the neurological situation. So this is a child, perfectly well-grown child. All the measurement parameters are normal. All on a sudden happening weakness, bilaterally symmetrical lower part and later upper aspect also. So when such a weakness is happening over hours, so it's very, very important. So how fast it is progressing from nil to worse. So prognostically important, decision making is important. Apart from that, the etiological clues which you need to consider when such a progression over hours is happening. So as you said, the commonest things always common, demyelination, GBS is very likely. It's a very likely, not confusing. 90% possibility definitely is the demyelination. But as Smilo already pointed out, you need to consider bites and stings. You need to consider vascular pathologies and idiot artery block. You need to consider trauma. Sometimes it may not be forthcoming, child abuse and battered baby syndromes. And there are two entities which we again will be presenting. One is a myasthenic crisis, another is a channelopathy. And these two situations, the clues are in the past history. All the other three things, it can occur all on a sudden, first time. The other things, there will be clues in the past history. So all these 5 entities you need to consider when it is happening over hours. So very, very important. In the history, the other thing is go into the course of the illness. Of course, the onset part, the description, the neurological evolution, and up to the ventilation you have mentioned. So what is the present status? That was not mentioned in the history. So in the neurological problem, it's always, all these things are important. You need to answer it sequentially. Is there a neurological problem? So the first possibility you want to consider is a pseudoparalysis situation. So you answer there's a neurological problem, it's not a pseudoparalysis. Then what exactly, where exactly is the neurological problem, anatomical localization. And for all these things, the onset, course, and evolution, the present status. So they were lacking, those last part were lacking. What is the present status is still not mentioned. And in the initial part, when there is a solo problem, a little more is to be mentioned, because that is a forerunner of an argument. You have already told about the scoring system and the need for ventilation, the fast progression of this from to thing, and the autonomic disturbance and the lower cranial things are all very, very important. So a little bit more elaboration. And in the past history, the history purpose is other entities, pathological basis. So each of these entities you need to go a little more in depth. The nutritional, there can be a possibility of a poisoning bar deficiencies. In the family history again, the possibility of some of the degenerative neurodegenerative disorders also occurs, like the metatraumatic leukodystrophy, sometimes can present like this. It's the rarest of the rare situation. Still, if there is any family history, the channelopathies, some of the neuromuscular disorders, all these things. So, 3 pedigree chart with the 3 generation you need to go. So, each of the past histories are helping for the pathological basis. So, you need to give trust to all those areas. In the general examination, after you have described the attitude poster, in the white, there is very, very important thing you just missed that you didn't give importance. The BP was 96 bar, that is a BP. Always, rather than mentioning the BP, always say what centile is it. It's very important. The pulse is 96 or so. So both the pulse, the rhythm, rate, and the BP is very, very important, because that is prognostically important. Don't underestimate. So in the general examination again, apart from the neurological part, all pathological problems you need to screen, like your pigmentation for nutritional problems, for the rashes, for the neurocutaneous markers, and the compulsive myelopathy is possible, lymph node, other malignancies rarely, and the evidence of trauma, baby syndrome. So in the general examination, that was not completed. That's it. All the clues for the pathological basis also to be covered there. In the examination, when you come to general the cranial nerves, CNS, all of us are trained to tell no deviation of the. When you are expecting a bilateral weakness of whatever is called, that is a meaningless thing. What sort of a weakness you get in the case of bilateral facial weakness? What is the functional involvement? The 2-year-old child, that will be affecting the sucking of the breast. Straw using and drooling. What is happening? How he is feeding? a little bit more about the feeding part is very, very important. So in the initial part, was there any doing? What about the coordination? Was there any following well planned? So when we are discussing about the poliomyelitis and all, the feeding very, very important. Coordinated manner of the feeding. So give importance to the cranial area. Okay. In the examination also, the autonomic disturbance, both dryness and the sweating part, because the younger child may not be able to make out the other sensory. Okay, and that was all. And in the tool, he mentioned one of the things he mentioned was about considering about the convolular actor. There is a possibility of another thing is in the botulinum, and of course, as at the end of this thing, the program part, every control program will be asked in detail. And one more thing, in the examination, examiner will be interested about the polio, the world level, what is it? Weekly reporting, how many cases of polio there in the world, in Nigeria and Pakistan, total number in this year, last year, all those questions are very likely to come. The program part should become, you should be knowing, and about the polio part, all these things are important. Okay, well discussed. Well,
Thank you, sir.
Thank you, sir.
I was also about to say about that facial nerve involvement. It's usually bilateral, so you have to mention in that way. It is a usual, very often it is presented like that. Whenever you expect a symmetrical involvement, not only in GBS, sometimes in myopathy, sometimes. So whenever you expect a symmetrical involvement, so you need, in myopathies, I have seen students saying that the bulk is equal bilaterally, but in myopathy, you expect the bulk to be equal but reduced. So that aspect is also important. So here also similarly, you are expecting bilateral facial nerve, so you should say that aspect. And another comment, not about the presentation of the case. Sometimes in young children, it is very difficult to suspect. Sometimes it may they may be just crying because of the paresthesia. You may not get any clue. Sometimes the weakness may not be that significant initially. Sometimes you may think that there is some pain somewhere. Sometimes the hip problems. I know it is like that. So in young children, sometimes it may be very difficult, and you have to dig the history in very detail to get the clue. That's all. It was the presentation was excellent, and the discussion was also very nice. Any other comments, Sindhu? Aslam, any comments?
No, sir.
Next discussion, there is one question. Next discussion will be on next. Every week we have the program. So the details about the case will be shared in next 1 or 2 days. If I think we can close the session. Aslam can close the session.
Good evening. Good evening, all. First of all, I congratulate Dr. Smilo Mohanlal for your clear and excellent discussion. Thank you, Dr. Smilo. Next, I thank Dr. Shagufa for your clear and lucid presentation. Also, I thank Dr. Shyamadas for mentoring the presenter in an excellent way. Next, I thank our scientific convener, Antakeshav sir, state coordinator, Mohandas sir, for your great support for the smooth conduct of this scientific program. Actually, Mohandas sir is taking great effort for the regular conduct of this program, and this PG group discussion is getting great acceptance among the PGs and practitioners all over the country. Thank you, sir. Also, I thank State Vice President Dr. Prashant and senior faculties like Purushothaman sir and all others who participated in this scientific session and made it a big success. And the last and most importantly, I thank the IFP Calicut organizing team headed by Sindhu Madam, Dr. Jishin, Dr. Vinita, Dr. Enjit, who worked behind the curtain and to make it a grand success. And thank you all once again.
Thank you. Good night.
Thank you. Good night.
Good night.
Thank you, sir. Good night. Good night.